Okay, hello everyone. Our mentored project is called Community Engagement Alliance for Asian American, Native Hawaiian, and Pacific Islanders, and it's mental health expanding access and support in the San Joaquin Valley.
Hi, everyone. My name is Shradha Kesari, and I'm a rising senior at Irvington High School, and I love to play basketball.
And I'm Isabella Medina. I go to Merced High School. I play cross country, and I'm also a rising senior. So some background on our project. It is focused on mental health concerns among Asian American, Pacific Islanders, and Native Hawaiians. And mental health among these communities is on the rise. However, these communities are also one of the most likely not to seek mental health services. So in our project, we're working with these communities to see how they experience mental health in the San Joaquin Valley. So this community is very diverse and growing, but they're also very under-researched and underserved. And also, here's a little picture of the San Joaquin Valley right there compared to San Francisco.
Okay, so for our project description, we were mainly focused on mental health and the experience for the AA and HPI community in San Joaquin Valley. And what we were doing is we had 11 interview transcripts, and these interviews were conducted with the county and nonprofits and other organizations such as clinics in San Joaquin Valley between February and March of 2024. And so we have these 11 transcripts, and our job was to code and analyze them. So going further into our method, I mentioned that we had 11 transcripts, and 5 of them were analyzed for our preliminary findings. We had our team at UC Merced interview clinics, counties, and other nonprofits, and our entire coding process was qualitative. So it's not like using Python or Java or something like that. No, it was qualitative coding. And basically what qualitative coding does, it is that it identifies patterns and themes that we see across our transcripts. And it enables us to compare these transcripts and the themes that we see across them. So what we did was we created a code book, and then we created a finalized master transcript with our codings on them. And then we analyzed these master transcripts, and then we identified common themes among all of our transcripts. So this is what a code book looks like. So on the left, you'll see our code, and then on the right, you'll see the description. So this way, we can make sure that our coding is systematic and consistent between all of our transcripts. And so we have the parent codes, which are the main codes that you see. And then below them, we have the child codes. They're called child codes and parent codes because they're connected like a family. And this is what a coded transcript looks like. So we used a platform and a software. It's called Atlas TI, and we used it at UC Merced. And in total, we have 34 codes, although 18 were showed previously. And, oh, my apologies. This is the coded transcript. That was the other picture of our codebook. Yes, so this is what our coded transcript looks like, and it allows us to code the transcripts. And Atlas has a bunch of really cool features which help us actually analyze these transcripts systematically. It shows us which codes were most frequently used and which quotes were captured under each of those codes across all of the transcripts and other such features.
So from across these transcripts, these are the 3 main codes or themes that we saw the most often. So accessibility, above and beyond, and holistic health were the most common themes across the 5 transcripts we reviewed. So accessibility, the definition of this would be the barriers to obtain mental health services. And the codes that fall under this would be things like insurance, navigation, and time commitment. So for insurance, it would be like the barriers to access mental health services because they can't access their insurance to cover their service. And navigation would be like a complicated system for mental health services. And time commitment would be the rural communities that the Asian American, Native Hawaiian, and Pacific Islanders come from. And it would take a long time for them to go to the location of the mental health services. And here's a quote from one of the transcripts from a nonprofit, and it reads, "If you have mental health and you're insured, but you live in one of the rural communities, there's no mental health provider. So for you to access services, you are having to drive back to Fresno, back to Merced. So depending on where you live, you may be driving 45 minutes to an hour each way, plus your hour session. Well, that's potentially 3 hours out of your day. And if your symptoms or need has you meeting not bi-weekly or monthly, but you need to come in weekly, that's 3 hours I'm taking off. So this will show how time commitment can be an accessibility barrier to reaching mental health services for these communities.
Our next most common theme that we saw across our transcripts was going above and beyond. So this is when providers really show efforts and care, and they value their patients, and they exceed the standards for mental health care. So the codes that fall under this are outreach, recovery language, and wraparound services. Outreach is when a mental health service connects with other services such as insurance providers or other such providers, and they try to connect their patients with them to make sure that they get overall care. Recovery language is when the provider makes sure to change the language that in which they speak about mental health. So instead of calling it mental health, they'll call it like something similar to taking care of your mind. Or an example that we saw in our transcripts was when a mental health provider called their clinic a happy house instead of a mental health clinic. And our third most common code that we saw under this theme was wraparound services. So wraparound services is when the mental health provider themselves, they provide other services too, such as insurance or like immigration, tax, housing services, similar things to that. And so this is a quote that we saw from our transcript, and it was from a transcript with a nonprofit. It reads, we have our health and wellness department, which we help families with housing, public assistance, Medicare, unemployment. And then, of course, we have victim service department, which we have community members to file for restraining order and so forth. So I'm pretty sure any home visitation program, as well as a parenting class program, so might have them in our programs or departments. So basically, the way that we see this as going above and beyond is in the way that this provider provides their clients or patients with housing, public assistance, Medicare, and unemployment services.
And for our final code or theme, we have holistic health. And this is services and practices that encompass the person as a whole for these communities. So things like these would be alternative healing, so such as offering spiritual or religious services, community engagement like social and group therapy, and cultural humility, which is where the provider practices and learns to understand the patient's culture. And here's a quote from a nonprofit, and it reads, if they want to see a shaman, I can get a shaman to come and see them. If they feel like they need a pastor, I can get a pastor to come and pray for them. If they feel like they need a monk or something like that, so we don't just focus on their mental health, we focus on them as a whole. And so that's the holistic approach, just focusing on mental health.
Okay, so past this research, our next steps are to continue coding our transcripts and finish the rest of our 6 transcripts. Then we'll compare our results with our partners. So we're actually partnering with other campuses such as Stanford and UCLA to get a more holistic view of how the AA-NHPI community experiences mental health service in California and all across California. And then our final goal is to inform more community-driven mental health care across California.
And here are some of our reflections. Both of us realized that access to mental health care isn't a one-way path. It requires understanding and effort from both the patient and the provider, along with cultural humility being a big part of this, especially with patients from different cultural backgrounds. So understanding the AA-NHPI community, even if the providers cannot relate to their cultural background, is still important for them to make an effort to understand and learn their culture.
We'd like to thank our mentors, Dr. Kessia Garibay here in the audience, and Dr. Nancy Burke. We'd also like to thank the rest of our team at UC Merced, and we'd like to thank the rest of the UCGHI SRGH team, our guest lecturers, our families and friends, and you all. Thank you.
Thank you so much for that presentation. One of qualitative research methods are just really great ones to learn as an early learner. And one of the things I really appreciated was hearing a lot that you were looking both at barriers and facilitators, the things that actually work very well. As you go forward, so in this case, you were talking to kind of the providers or reading transcripts from providers. So the clinics, the nonprofits that are working in the area. If you were to design the study, not that you would have to know the answer to this, and you wanted to now include the community themselves, community members themselves, what kind of questions would you be interested in kind of coming out of this study so far?
I think that's a really interesting question. Well, personally, I'd want to see how they experience mental health, and like hearing the story from their end is obviously very different from what the provider understands. So like what we've seen is the provider thinks that they might be providing different services that they think work for their patients, but it's not always the same. So we want to talk to the providers and ask them what they're doing and what services they're providing. And then we'd also want to ask how the patients are receiving that themselves. Do you have anything to add?
I think maybe if they have anything from their culture that prevents them from reaching mental health services as well, like if they see it differently, like if it's taboo or there's shame associated with it, that would also be interesting to ask as well.
I don't know if you had access to this kind of information or if your data set was large enough, but did you notice any trends with regard to age or location within the valley or a profession? Like, are people within the AA-NHPI community experiencing these in different ways depending on who the individuals are, I guess?
I think the main thing that we were looking at in our study was we were looking at interviews with the provider and not with the patients themselves. So we don't really know much about the age trends or anything similar to that with the patients themselves. But at UC Merced, we do have other projects going on, like with the retired farm workers study, like the UC Merced, they're studying how retired farm workers access healthcare and what it's like for them. And then they also have another study going on with like the Punjabi community in the Central Valley. So those are studies that we'd see more of like a connection with the patients themselves and trends with that.